Welcome to Roadmap to Residency. Hello everyone, I am Aviraj. Welcome to our top 250 matchmaker sessions. We are currently in our nephrology modules and we will be running through some questions with you guys to help you on a journey to a 250. So, which of the following is the most likely cause of the patient's difficult to control hypertension and elevated serum creatinine? A 65-year-old man with a history of long-standing hypertension presents to the cardiology clinic for evaluation of difficult to control blood pressure. Despite being on multiple antihypertensive medications, his blood pressure remains elevated, and on examination, there is notable difference in blood pressure reading between the right and left arms, with the right arm consistently showing low blood pressure. Lab tests revealed an elevated serum creatinine levels. Duplex ultrasound of the renal arteries shows decreased blood flow and evidence of stenosis in the right renal artery. Which of the following is the most likely cause of the patient's difficult to control hypertension and elevated serum creatinine? Hyperaldosteronism, pheochromocytoma, renal artery stenosis, coarctation of aorta, or essential hypertension. So the patient's history of long-standing hypertension, difficult to control blood pressure, and the notable difference in the blood pressure reading between the arms are suggestive of renal artery stenosis. The presence of decreased blood flow and stenosis in the right renal artery on duplex ultrasound further supports this diagnosis. Renal artery stenosis can lead to the activation of renin, angiotensin, aldosterone system, resulting in hypertension and impaired renal function. Hyperaldosteronism can cause hypertension. The notable blood pressure difference between the arms is not the characteristic feature of this condition. Pheochromocytoma is associated with paroxysmal hypertension and is less likely to absent in the absence of episodic symptoms. Coarctation of aorta typically presents with elevated blood pressure in the upper extremities and low blood pressure in the lower extremities. And there is not a difference between arms in case of coarctation of aorta. Essential hypertension. Now, while essential hypertension is common, the presence of a notable blood pressure difference between the arms and renal artery stenosis on imaging suggests a secondary cause. Now, talking about the renal vascular disease, the unilateral or bilateral renal artery stenosis, okay, activates it causes the decreased renal perfusion, and it causes increase in the renin and increase in the angiotensin, and this all activates the renal angiotensin aldosterone system, leading to the uh, hypertension. The most common cause of secondary hypertension in adults is the renal vascular disease. So whenever there is proximal one-third or distal one-third of sort of obstruction there due to any cause, that it can cause ischemia and cause renin release, and this renin can convert angiotensinogen into angiotensin 1 and 2. Angiotensin 2 then causes the release of aldosterone, and it also causes the increase in the sodium retention and vasoconstriction, and these all processes consequently lead to the hypertension. The main cause of the renal artery stenosis is the atherosclerotic plaques. Now, atherosclerotic plaques primarily affect the proximal one-third of the renal artery, and it is usually in older males and smokers. The fibromuscular dysplasia is in the distal two-thirds of the renal arteries or segmental branches, and usually young or middle-aged females. For unilateral renal artery stenosis, the affected kidney can atrophy, and there can be asymmetrical kidney size. Renal venous sampling will show increased renin in the affected kidney and decreased renin in the unaffected kidney. For bilateral renal artery stenosis, patients can have a sudden rise in creatinine after starting an ACE inhibitor, angiotensin receptor blocker, or renin inhibitor due to the interference on RAS-mediated renal perfusion. You can present with severe or refractory hypertension, flash pulmonary edema, epigastric flank or bruit, and patients with renal artery stenosis may also have stenosis in other large vessels. Now, this is the typical pathogenesis and clinical findings associated with renal artery stenosis. So, either due to atherosclerosis or fibromuscular dysplasia, there is narrowing or stenosis of the renal artery, and it can be unilateral or bilateral. It can cause the decreased pressure perfusion in the kidney, decreased pressure gradient in the glomerulus, turbulent blood flow through the area of stenosis, and decreased renal blood flow leading to the ischemic renal injury. Now, decreased pressure perfusing the kidney can cause increase in the renin angiotensin aldosterone system activation. Now, it can cause hypertension. The decreased pressure gradient in the glomerulus will lead to the decrease in the glomerular filtration rate. The turbulent blood flow will lead to the abdominal bruit on side of the affected kidneys. Also, the ischemic renal injury will cause atrophy, and there will be atrophy and fibrosis of the affected kidneys. The unilateral stenosis, the kidney size asymmetry, more than 1.5 centimeter difference can be seen. Now, due to the hypertension, there is chronic left ventricular pressure overload, leading to the left ventricular hypertrophy, causing heart failure. Also, there may be increased secretion of aldosterone due to the activation of RAS, which is a part of the RAS system. Now, it can cause increase in the sodium water reabsorption from the renal tubular lumen into the blood vessels, and due to that, there may be decrease in the serum potassium concentration, leading to hypokalemia. So, which of the following is the most likely cause of the renal vein thrombosis in this patient? A 45-year-old woman with history of nephrotic syndrome presents to the emergency department with sudden onset left flank pain and hematuria. She also reports swelling in her legs and has been experiencing shortness of breath for the past 2 days. On examination, she is tachycardic and her blood pressure is elevated. Abdominal imaging reveals a thrombus in the left renal vein, and a ventilation perfusion scan shows multiple pulmonary emboli. Which of the following is the most likely cause of the renal vein thrombosis in this patient? Atrial fibrillation, hyperaldosteronism, nephrotic syndrome, renal artery stenosis, or chronic pyelonephritis. So the patient's history of nephrotic syndrome, sudden onset flank pain, hematuria, and the finding of thrombus in the left renal vein point to the renal vein thrombosis. Nephrotic syndrome is a non-prothrombotic state due to the loss of anticoagulant proteins in the protein in the urine, leading to an increased risk of thrombus formation. So the renal vein thrombosis is common in patients with nephrotic syndrome as a consequence in membranous nephropathy, membranoproliferative glomerulonephritis, and focal glomerular sclerosis. Yeah, the two-thirds of the cases are bilateral, and it can be due to endothelial damage, due to homocystinuria, endovascular intervention surgery. It can be due to venous stasis in case of dehydration and compression of renal vein via the retroperitoneal fibrosis. In case of hypercoagulable state like protein C and S deficiency, antithrombin deficiency, and factor V Leiden condition, there can be renal vein thrombosis. The clinical features may be acute or chronic. Acute, there is sudden onset flank or abdominal pain, gross hematuria, increased proteinuria, left-sided renal vein thrombosis can lead to varicocele, and there is acute decline in the GFR. In case of chronic condition, there may be dramatic increase in the proteinuria, and there is evidence of tubal dysfunction leading to glycosuria, aminoaciduria, phosphaturia, and impaired urinary acidification. The management is when symptomatic renal vein thrombosis, we need to treat with anticoagulants with low molecular weight heparin and warfarin. Anticoagulants do not break the performed clot, but can prevent the formation of a new clot. Now, some patients which are resistant to heparin therapy due to the severe antithrombin 3 deficiency. Now, the effect of oral anticoagulants like warfarin is decreased in nephrotic syndrome as the drug is bound to plasma protein and lost in the urine. Which of the following is the primary physiological role of angiotensin II in the RAS? Vasodilation, inhibition of aldosterone secretion, stimulation of renin release, decreased sodium reabsorption in the distal tubule, or inhibition of antidiuretic hormone. By just reading the last line first, you don't even need to read the rest of the vignette. So stimulation of renin release. The primary physiological role of angiotensin II in the RAS is to stimulate the release of renin. Angiotensin II acts on the JG cells of the kidneys, promoting the release of renin into the bloodstream. Now, renin in turn converts the angiotensinogen into angiotensin I, initiating the cascade that ultimately leads to the formation of angiotensin II. Now, this is the renin angiotensin aldosterone system. So when there is decreased BP, decreased sodium chloride, or increase in the sympathetic tone, now this will all stimulate the renin angiotensin aldosterone system. Now the JZ cells here will release renin, and this renin will convert angiotensinogen 1 to angiotensinogen 2, angiotensinogen to angiotensin 1. Okay. Now the angiotensin converting enzyme, which is secreted from the lungs and kidneys, converts angiotensin 1 to angiotensin 2. Now, this angiotensin II acts on various places. Number one, it acts on the angiotensin II receptor type 1 and causes vasoconstriction and increases the BP. It constricts the efferent arteriole, causing increase in the filtration fraction, and it preserves the glomerular filtration rate. It increases the sodium and H+ activity in the PCT cell, and it causes the reabsorption of sodium, water, and bicarbonate. It acts on the adrenal gland, and it increases the aldosterone secretion. Now, this aldosterone acts on the alpha cell and the principal cell to increase the H+ secretion and sodium reabsorption. Angiotensin II also acts on the hypothalamus, and it stimulates the hypothalamus to release the ADH. Now, this ADH reacts on the principal cell and causes the water reabsorption. Thank you for watching. Keep